Welcome. This is the New England Journal of Medicine. I'm Dr. Lisa Johnson. This week, June 20th, 2024, we talk about combination therapy for diffuse large B-cell lymphoma, autosomal dominant Alzheimer's disease, noninvasive ventilation for preoxygenation during emergency intubation, a novel anti-CD38 antibody in immune thrombocytopenia, and a glucose-responsive insulin for type 2 diabetes, a review article on congenital and acquired Chiari syndrome, a case report of a man with arthritis and rash, and perspectives on ethics and innovative research on brain diseases, on sustaining and scaling up street medicine, and on the maternal crossroad. Combination targeted therapy in relapsed diffuse large B-cell lymphoma by Christopher Milani from the National Cancer Institute, Bethesda, Maryland, and co-authors. The identification of oncogenic mutations in diffuse large B-cell lymphoma, DLBCL, has led to the development of drugs that target essential survival pathways. But whether targeting multiple survival pathways may be curative in DLBCL is unknown. This single-group trial assessed the efficacy and safety of VIPER, a 5-drug combination of targeted therapies including venetoclax, ibrutinib, prednisone, and lenalidomide and obinutuzumab in relapsed or refractory large B-cell lymphoma. In Phase 1b of the study, involving 20 patients, a single dose-limiting toxic effect of grade 3 intracranial hemorrhage occurred, a result that established venetoclax at a dose of 800 milligrams as the recommended Phase 2 dose. Phase 2 included 40 patients with DLBCL. Toxic effects that were observed among all the patients included grade 3 or 4 neutropenia in 24% of the cycles, thrombocytopenia in 23%, anemia in 7%, and febrile neutropenia in 1%. Objective responses occurred in 54% of the evaluable patients with DLBCL, and complete responses occurred in 38%. Complete responses were exclusively in patients with non-germinal center B-cell DLBCL and high-grade B-cell lymphoma with rearrangements of MYC and BCL2 or BCL6, or both. Circulating tumor DNA was undetectable in 33% of the patients at the end of VIPER therapy. With a median follow-up of 40 months, 2-year progression-free survival and overall survival were 34% and 36%, respectively. Treatment with VIPER was associated with durable remissions in patients with specific molecular DLBCL subtypes and was associated with mainly reversible adverse events. Jordan Goldstein and Ash Elizada from Stanford University, California, write in an editorial that Milani and co-authors present compelling early clinical evidence that the drug combinations in VIPER, especially the combination of venetoclax and lenalidomide, provide synergistic cytotoxicity in activated B-cell ABC large B-cell lymphoma. The approach mimics 3-week chemotherapy cycles of 2 weeks of active treatment and 1 week off. This rational combination of targeted therapies in relapsed or refractory large B-cell lymphoma represents an innovative chemotherapy-free treatment design with curative potential. However, the interpretation of results from the current study is limited by its single-group, single-center design, and future multi-center trials are needed to confirm the results. Although anti-CD19 CAR T-cell therapy has proven effective as treatment at the second line and beyond, access to CAR T-cell therapy remains an issue for many patients and providers. As a combination of oral and intravenous targeted therapies, Viper can be easily administered in the community setting. However, combining multiple targeted agents is costly. In addition, although all the component agents are approved by the Food and Drug Administration for other hematologic cancers, none are currently approved for treatment of patients with diffuse large B-cell lymphoma, which poses a potential impediment to on-label access. ApoE3 Christchurch heterozygosity and autosomal dominant Alzheimer's disease by Yakil Hirose from Massachusetts General Hospital, Boston, and co-authors. Variants in ApoE and PSEN1, encoding apolipoprotein E and presenilin-1, respectively, alter the risk of Alzheimer's disease. These authors previously reported a delay of cognitive impairment in a person with autosomal dominant Alzheimer's disease caused by the PSEN1 E280A variant, who also had 2 copies of the apolipoprotein E3 Christchurch variant. Heterozygosity for the apolipoprotein E3 Christchurch variant may influence the age at which the onset of cognitive impairment occurs. The authors have now assessed this hypothesis in a population in which the PSEN1 E280A variant is prevalent. Data was analyzed from 27 participants with 1 copy of the apolipoprotein E3 Christchurch variant in a kindred from Antioquia, Colombia. Among carriers of PSEN1 E280A who were heterozygous for the apolipoprotein E3 Christchurch variant, the median age at the onset of cognitive impairment was 52 years. In contrast to a matched group of PSEN1 E280A carriers without the apolipoprotein E3 Christchurch variant, among whom the median age at the onset was 47 years. PET imaging findings from 2 participants heterozygous for the apolipoprotein E3 Christchurch variant showed limited tau pathological findings and relatively preserved glucose metabolism. 4 studies of autopsy material obtained from persons with the apolipoprotein E3 Christchurch variant and PSEN1 E280A variants showed fewer vascular amyloid pathologic features than were seen in material obtained from persons who had the PSEN1 E280A variant, but not the apolipoprotein E3 Christchurch variant. Clinical data supported a delayed onset of cognitive impairment in persons who were heterozygous for the apolipoprotein E3 Christchurch variant in a kindred with a high prevalence of autosomal dominant Alzheimer's disease. In an editorial, John Hardy from the University College London writes that the protective variants of genetic loci are of particular interest for 2 reasons. First, because they are important from a clinical genetic perspective, and second, because they may give mechanistic clues about potential therapeutic strategies. Genetic variation at the ApoE locus is, by far, the most important determinant of risk of Alzheimer's disease discovered to date. Despite this, we have relatively little understanding of its pathogenic role, beyond the fact that genetic variation is closely associated with amyloid deposition. The effects of the protective apolipoprotein E3 Christchurch variant and the many other rare variants that are associated with increased and decreased risks of both Alzheimer's disease and blood lipid disorders perhaps offer starting points for cell biologic and transgenic work designed to dissect these mechanisms. Both the current work and previous work certainly suggest that understanding the precise dynamics of the interactions among ApoE variants and their many receptors in both the central and peripheral nervous systems may yield important clues. In this regard, the recent report that genetic variation in the low-density lipoprotein receptor-related protein 1b locus may also influence the age at onset of Alzheimer's disease in the Colombian kindred may be relevant. Clearly, the time is ripe for a focused and detailed study of the pathogenic involvement of ApoE in Alzheimer's disease. The dissection of the biochemical characteristics of the various ApoE alleles will undoubtedly play a crucial part in such an investigation. Non-invasive ventilation for preoxygenation during emergency intubation by Kevin Gibbs from Wake Forest School of Medicine, Winston-Salem, North Carolina, and co-authors. Among critically ill adults undergoing tracheal intubation, hypoxemia increases the risk of cardiac arrest and death. Preoxygenation, the administration of supplemental oxygen before induction of anesthesia, increases the content of oxygen in the lung at induction and decreases the risk of hypoxemia during the tracheal intubation procedure. In current clinical care, most critically ill adults receive preoxygenation by means of an oxygen mask. Oxygen masks are simple to set up and can deliver a fraction of inspired oxygen, FiO2, as high as 100% under ideal conditions. However, oxygen masks do not provide positive pressure or ventilatory support, and the actual FiO2 received may be as low as 50% when ambient air is entrained around a loose-fitting mask. Non-invasive ventilation, which involves the use of a tight-fitting mask and a high gas flow, can deliver an FiO2 of 100%, provide positive pressure, and support ventilation. However, non-invasive ventilation requires more time to set up and could potentially increase the risk of aspiration of gastric contents during intubation. In this trial, conducted at 24 emergency departments and intensive care units in the United States, 1,301 critically ill adults undergoing tracheal intubation were randomly assigned to receive preoxygenation with either non-invasive ventilation or an oxygen mask. Hypoxemia occurred in 9.1% of patients in the non-invasive ventilation group and in 18.5% of patients in the oxygen mask group. Cardiac arrest occurred in 0.2% of patients in the non-invasive ventilation group and in 1.1% of patients in the oxygen mask group. Aspiration occurred in 0.9% of patients in the non-invasive ventilation group and in 1.4% of patients in the oxygen mask group. Among critically ill adults undergoing tracheal intubation, preoxygenation with non-invasive ventilation resulted in a lower incidence of hypoxemia during intubation than preoxygenation with an oxygen mask. A novel anti-CD38 monoclonal antibody for treating immune thrombocytopenia by Yunfei Chen from the National Clinical Research Center for Blood Diseases, Tianjin, China, and co-authors. Immune thrombocytopenia, ITP, is an autoimmune disease characterized by autoantibody-mediated platelet destruction. Treatment with CM313, a novel anti-CD38 monoclonal antibody, can result in targeted clearance of CD38-positive cells, including plasma cells. This Phase 1/2 open-label study evaluated the safety and efficacy of CM313 in 22 adult patients with ITP. CM313 was administered intravenously at a dose of 16 milligrams per kilogram of body weight every week for 8 weeks, followed by a 16-week follow-up period. 21 patients, 95%, had a primary outcome of 2 consecutive platelet counts of at least 50 times 10 to the ninth per liter during the treatment period, with a median cumulative response duration of 23 weeks. The median time to the first platelet count of at least 50 times 10 to the ninth per liter was 1 week. The most common adverse events that occurred during the study were infusion-related reaction in 32% of the patients and upper respiratory tract infection in 32%. In this study, anti-CD38 targeted therapy rapidly boosted platelet levels by inhibiting antibody-dependent cell-mediated cytotoxicity on platelets, maintained long-term efficacy by clearing plasma cells, and was associated with mainly low-grade toxic effects. Congenital and acquired Chiari syndrome. A review article by Robert Friedlander from the University of Pittsburgh Medical Center, Pennsylvania. Chiari malformation, an anomaly of the posterior cranial fossa, was described in autopsies by Hans Chiari, an Austrian pathologist, in 1891. He defined 4 distinct anatomical configurations in which the cerebellar tonsils, the most caudal part of the cerebellum, protruded below the lower margin of the foramen magnum. Several subtypes have subsequently been described, often in association with other anomalies, but the essential feature remains the descent of the cerebellar tonsils below their normal position just above the rim of the posterior fossa. In adults, symptoms from adult Chiari malformation most commonly develop before the age of 45 years, with an approximate female-to-male ratio of 3:1. Whereas in pediatric Chiari malformation, the mean age at presentation is 8 years, with an approximately equal female-to-male ratio. The most common symptom is headache, which is most likely due to transiently increased intracranial pressure from partial blockage of the flow of cerebral spinal fluid. The headache is usually suboccipital and dull or throbbing, but it can be located anywhere in the cranium and have other characteristics, including migraine and tension-like discomfort. Chiari headaches are characteristically exacerbated by Valsalva-like activities, such as coughing, laughing, sneezing, straining, lifting heavy objects, and changing body or head positions. An additional symptom, which is independent of but often associated with headaches, is paresthesia in one or both hands, often involving all the fingers without a radicular distribution. Similar symptoms can occur in the feet, although this location is less common. The Chiari syndrome is treated surgically. A 46-year-old man with arthritis and rash. A case record of the Massachusetts General Hospital by April George and co-authors. A 46-year-old man was evaluated in the rheumatology clinic because of arthritis and rash. 1 week earlier, an episode of lightheadedness occurred when the patient stood up from a seated position. The episode was associated with diaphoresis and mild nausea. It lasted for a few minutes and resolved spontaneously. 4 days later, another episode of lightheadedness occurred, and the patient sought evaluation in the emergency department. On evaluation, swelling of the wrists and ankles was present. The erythrocyte sedimentation rate was elevated at 104 millimeters per hour. 3 days later, the patient was seen in the rheumatology clinic. Additional history was obtained. 4 months earlier, mild COVID-19 had developed in the patient after he had returned from a vacation in Central America and the Caribbean. 1 week after the resolution of COVID-19 symptoms, pain and swelling of the wrists had developed. In addition, a rash involving the chest, back, and legs had developed. The palms and soles were spared. Alopecia, anorexia, and an estimated 8 kilograms of weight loss had also occurred. The examination was also notable for nasal crusting. The patient reported having a new male sexual partner. Syphilis can cause oligoarticular or polyarticular inflammatory arthritis, and the secondary stage of syphilis can result in a macular or papular rash with scaling on the trunk, arms, and legs. Syphilis can cause reversible patchy alopecia with a classic moth-eaten appearance, with diffuse small patches of hair loss. Overall, secondary syphilis was the most likely diagnosis in this patient. A treponema-specific antibody test and a rapid plasma reagent test were reactive. Engineering an insulin complex to treat diabetes. A clinical implications of basic research by William Cefalo and Guillermo Ariaza Rubin from the National Institutes of Health, Bethesda, Maryland. It has been more than 100 years since the discovery of insulin, an advance that changed diabetes from a disease associated with substantial morbidity and mortality to a manageable chronic condition. Today, insulin therapy is closer to the goal of mimicking physiologic endogenous insulin profiles with the availability of rapid and long-acting insulin formulations, continuous glucose monitoring, and hybrid closed-loop systems. Yet many persons with diabetes who receive insulin therapy continue to have unmet insulin needs and may remain with extended intervals of blood glucose levels above and below the recommended targets. Innovations to improve insulin therapy include the engineering of insulins that primarily act on the liver, as well as SMART or glucose-responsive insulins, GRIs, which are active when the blood glucose level increases and inactive when the level is in the normal range. They mimic beta cell function by releasing insulin when needed on the basis of varying blood glucose levels, increasing time in range for daily glycemic excursions, and reducing hypoglycemia or hyperglycemia in persons with diabetes. Of interest, then, is a new type of subcutaneously injected GRI reported by Zhang and co-authors. These authors evaluated their GRI conjugate according to its capacity to replace both prandial and basal needs during laboratory-based assessments and preclinical mouse and mini pig models. The study adds to the growing body of work on GRIs and provides proof of concept for a biodegradable insulin complex formulation that releases insulin in a glucose-responsive manner, showed long-term efficacy in vivo, and appeared to have minimal toxicity. However, additional studies are required. Ethics and highly innovative research on brain diseases. A perspective on the fundamentals of medical ethics by Saskia Hendricks and Christine Grady from the National Institutes of Health Clinical Center, Bethesda, Maryland. The human brain is the object of endless fascination, given its centrality to identity and many core functions, including production of thoughts, emotions, and actions. Patients may therefore attribute distinctive meaning to brain diseases and interventions. The devastating toll of neurologic and psychiatric disorders makes seeking knowledge and developing interventions by means of brain research an ethical imperative. Deeper understanding of the brain could also change our notions of what is uniquely human and of death, agency, responsibility, and other concepts underlying fundamental societal norms and laws. Our increasing ability to record, understand, and directly modify the brain has led research to a new frontier, where calls are being made to protect the right to mental self-determination. Despite exciting advances, conducting brain research and appropriately implementing interventions or insights derived from it raise both familiar and new ethical challenges. These authors discuss a few specific yet hypothetical cases based on existing innovative brain research that can help illustrate these challenges. The first involves the care of a patient after the patient was involved in a clinical trial of a highly innovative brain implant. 3 years later, the implant has stopped working. The device company had declared bankruptcy, and the replacement parts are no longer available. A second sample scenario features the decoding of the human brain. A third case discusses work on neural organoids. Brain research has enormous promise, but raises ethical challenges that require more than simple regulatory compliance. Healthcare beyond clinic walls. Sustaining and Scaling Up Street Medicine. A perspective by Michael Liu from Harvard Medical School, Boston, and co-authors. At any given time in the United States, roughly 650,000 people experience homelessness, of whom approximately 40% are unsheltered. The unsheltered homeless population has reached its largest size since national reporting began in 2007. The street medicine movement has emerged as a response to the unsheltered homelessness crisis and was born out of the need to bring healthcare directly to patients in their own environments. Street teams, which are typically composed of prescribers, nurses, social workers, and peer navigators, many of whom have personal experience with homelessness, provide comprehensive care for both acute and chronic conditions, including vaccines, wound care, and medication for substance use disorders. Some street teams function as temporary bridges to brick-and-mortar clinics, whereas others aim to serve as more permanent sources of care for patients experiencing chronic homelessness. The Centers for Medicare and Medicaid Services recently created a new Place of Service Code, Place of Service Code 27, for the treatment of unsheltered patients, which went into effect in October 2023. This policy change presents an opportunity to enhance the financial viability of existing street medicine programs and represents a leap forward. But health systems, payers, and policymakers could take additional steps to bolster street medicine. First, the street medicine workforce is insufficient to care for the growing unsheltered population. Furthermore, more policy flexibility and additional financial support are necessary. The Maternal Crossroad. A perspective by Larissa Matei from Wayne State University, Detroit. On the first day of her final year of residency, Dr. Larissa Matei's parents called from the emergency department to read her mother's CT report. Peritoneal carcinomatosis, a large pelvic mass. Dr. Matei's pulse roared in her ears as she felt the air being sucked from her lungs. Her mother, stoic as ever, asked, "What do you think it is?" Dr. Matei hung up the phone and immediately vomited. The next morning, Dr. Matei's husband drove the car as Dr. Matei cried across 6 states and 14 hours of highway traffic to be with her mom during her surgery and recovery. A heavy, aching dread bloomed in the pit of her stomach. How terrible and breathtaking to see the end from the beginning. As a gynecologic oncologist, Dr. Matei has sometimes struggled with the best way to guide patients through their surveillance visits. Where does careful reassurance end and false promising begin? What is the right balance of pragmatism and optimism? Dr. Matei strives to be an impartial shepherd through her patients' cancer treatments, but found these lines more blurred than usual with her own family. While still in the midst of treatment, her mother came to stay with Dr. Matei, who had given birth to a daughter. Even on her bad days, Dr. Matei's mother cooked for them or folded laundry, and they fell into the roles they had known for Dr. Mattei's entire life. With the start of her clinical years of fellowship in gynecologic oncology, Dr. Mattei found herself at a similar and, at times, suffocating crossroads, where physician, mother, daughter, and wife converge. Her mother's health was declining as Dr. Mattei's clinic hours grew longer. In our Images in Clinical Medicine, a 32-year-old man presented with a 7-year history of skin nodules and swelling, pain, and morning stiffness in his fingers and knuckles, along with smooth nodules over the chest, ears, and fingertips. X-rays of the hands showed marginal erosions of multiple interphalangeal joints. Histopathological examination of a skin biopsy sample obtained from a chest nodule showed histiocytes and multinucleated giant cells with abundant eosinophilic granular ground glass-like cytoplasm in the dermis, hyperplasia of fibrous tissue, and acute and chronic inflammatory cell infiltration. A diagnosis of multicentric reticulohistiocytosis was made. This condition is a rare systemic form of non-Langerhans cell histiocytosis that is characterized by erosive arthritis and skin lesions. It may be misdiagnosed as rheumatoid arthritis owing to the presence of inflammatory arthritis and periarticular skin nodules. In another image, a 65-year-old man with type 2 diabetes presented to the hospital with a hyperosmolar hyperglycemic state. 2 weeks earlier, the patient's insulin dose had been increased owing to inadequate glycemic control. The physical examination was notable for confusion and sarcopenia. There were also rubbery subcutaneous masses on either side of the umbilicus, where the patient had been repeatedly administering insulin injections, a finding known as insulin-induced lipohypertrophy. Insulin-induced lipohypertrophy is a type of localized lipodystrophy that results from repeated subcutaneous injections at the same site. It may lead to a decreased response to insulin therapy and volatile glycemic levels. Lipohypertrophy may be difficult to detect in patients with obesity, but masses are usually palpable on abdominal examination. Patients who use subcutaneous insulin should be examined for injection site complications at every clinic visit and should receive counseling regarding the importance of rotating injection sites to allow sites to heal. In this patient, laboratory studies were notable for a glycated hemoglobin level of 11.4%. After 48 hours of treatment with insulin and intravenous fluids, the patient's hyperosmolar hyperglycemic state resolved. This concludes our summary. Let us know what you think about our podcast. Any comments or suggestions may be sent to audio@nejm.org. Thank you for listening.